I'm Dr. Michael Kessler, the Chief of Hand Surgery at MedStar Georgetown University Hospital. I take care of people who suffer from traumatic injuries, anywhere basically from the fingertip to just above the elbow. We take care of people who have degenerative conditions such as arthritis or nerve compressions that cause them to lose sensation or sensibility in their hands or fingers. I take care of carpal tunnel syndrome, trigger fingers, arthritis of the fingers and hands, and multiple types of fractures or tendon lacerations. Most of the time we're able to do surgery in an outpatient setting where patients can go home and be in the comfort of their own home by the end of the day. That is because of more modern surgical techniques and because of more modern anesthesia techniques where they're able to specifically numb the area that is in question for surgery and not have to give complete general anesthesia all the time. With hand surgery, I can get people back to doing the things they enjoy, and it takes a bit of precision to get people back to writing their name properly or doing their artwork or playing their musical instrument back to the level that they wanted to perform at. We have hand surgeons, we have hand therapists. That is an occupational therapist who has done 5 years of extra training, just training in how to take care of people in their hands and their wrists. We have people who can do nerve conduction studies and other neurology procedures to evaluate for some degenerative conditions. We have musculoskeletal trained radiologists who can specifically inject the fine small joints of the hand to make sure there are ligament injuries or cartilaginous injuries. And we all work together as a team to find out what's wrong with the patient and come to a good conclusion of how to treat them all appropriately. Because the key is not treating the image, not treating the x-ray, not treating the MRI, but treating the person. There are a few parts of the body that are very personal. The hands and the eyes are the two main ones that people say, you know, I can have surgery on my knee any day, or I could have surgery on my stomach, or XYZ, but my hands are, you know, that's what makes me me. That's what makes me be able to do what I want to do. So people who type all day, people, like I said, who are artists, people who are athletes, they get very concerned that they're not going to be able to do their stuff, whatever their stuff may be. So I take it personally and I take it to heart, and I know as a surgeon my hands are clearly my life, that, you know, you can't just be whimsical about taking care of people's hands. Some of the most common conditions that I take care of with respect to the hand and wrist that require surgery can be something acute like a fracture, a broken wrist, a broken hand, broken finger. Can be something degenerative such as carpal tunnel syndrome, something from repetitive use such as a trigger finger or a tendinitis on the radial side of the wrist, which can happen in new moms very frequently when they're holding their babies while breastfeeding. Or it could be something more degenerative, such as arthritis, where we reconstruct the base of someone's thumb if they are having difficulty pinching and using their hand for activities. No, and I think that's important, and I talk about this with patients regularly. I love doing surgery, but I only love doing surgery for the right reason and on the right person. And I don't think the knee-jerk reaction from a good surgeon is to do surgery right away. I think we can treat a lot of these conditions with cortisone injections, bracing, splinting, therapy, or any other modality without jumping right into surgery. Especially if we can delay the surgery for a few years and let someone continue being productive in their daily life or in their leisure life without having to take time away from that recovering from surgery. Carpal tunnel syndrome is the most common thing that people think they have that they don't actually have. So carpal tunnel syndrome is numbness and tingling in the thumb, index, long, and half of the ring finger. It's not pain, it's not weakness, it's not cramping, it's not any of the other things. It's not necessarily pain in the forearm, although carpal tunnel syndrome can move up the arm as well as down the hand. But the key findings are numbness and tingling in the radial 3 digits. We don't know what specifically causes it in one person or another. In twin studies, it has been shown that twins are more common to have carpal tunnel syndrome together. So there is some genetic component to having carpal tunnel syndrome. So it could just be that someone in your family somewhere had carpal tunnel syndrome or would have gotten it had they done an activity that would have predisposed them to it, and they just never did that. And now that you are a more active person or using your hands more often, that has kind of pushed you over the edge. The number one thing that does not cause carpal tunnel syndrome is typing. Every study that's ever been done has shown that typing does not cause carpal tunnel syndrome. It may exacerbate an underlying symptomatology of carpal tunnel syndrome, but on its own, it doesn't cause it. The only occupation that has been shown to cause carpal tunnel syndrome is using heavy vibratory machinery such as a jackhammer. There are lots of conditions that can predispose someone to carpal tunnel syndrome, and the main ones are age, being female, being obese, and or being pregnant. And those are all mutually exclusive. You don't have to be all of those things at once. The goal of carpal tunnel surgery is to decrease pain, to decrease night pain that can wake people up in the middle of the night. Those two things frequently get better with carpal tunnel release. The numbness and tingling, the paresthesias in the fingertips, the stinging that they feel will improve, but that will probably never completely resolve. And we also don't want it to get worse, because if the nerve is compressed and you're 65 years old, our life expectancy is now close to 80. So you can imagine over 20 years it will only get worse and lose function in the muscles in your hand. So if we can prevent those muscles from dying and make some of the pain and numbness improve, then that's a win. So on an everyday basis, when people come into my office, the thing I hear frequently is, does it really matter? It's just a finger. And the answer is yes, it matters, even though it's just a finger. Because that finger could lead to a neighboring finger being stiff, it could lead to the whole hand not functioning properly, it can lead to weakness in grip, it can lead to dropping things. And so making sure that the whole hand is functioning as a unit is very important. And so every little finger counts. The hand is a pretty complicated system of tendons, ligaments, nerves, bones, and they all interact with each other. For example, we have 8 carpal bones that sit between the radius and the metacarpal bones, and they all move around one another like gears. And so when you move your wrist in an outward position, then the bones shift one way, and you move it in an inwards position, they shift in another way. And it's very symmetrical, very much like a dance where the bones move around one another. And so if one ligament is torn and the bones can't communicate in their proper fashion, it can throw the whole system off and lead to arthritis. So the most important professional relationship that I have is the one with my hand therapists. And it's because I am only as good as the recovery and therapy that my patients get after surgery. Putting 2 bones back together is tough, but is a 1-hour process. The therapy of getting the tendons to glide over that bone, to not become scarred and adherent, to make sure the nerves are moving properly, to make sure the joints are supple and not stiff, is a long process requiring a lot of time, a lot of tender, loving care, and if it weren't for the therapists, patients wouldn't recover as well as they do. Therapy for hands is typically occupational therapy, and it can be performed most commonly by a certified hand therapist, which is a therapist who's done 5 years of extra training after completing occupational therapy training. Occupational therapists who are hand therapists also can make splints. They fabricate splints made of a hard plastic material called orthoplast, and they are educated into a variety of modalities that typical physical therapists don't perform. Therapy after surgery can last anywhere from a few weeks to a few months, depending on how involved the problem is, and can be on a spectrum from very passive motion to being more aggressive to trying to, break through contractures and adhesions that have formed because of lack of motion. therapy after hand injuries can definitely be painful. So having the right therapist who understands anatomy and understands what tolerance each different patient has is very important. Cortisone injection is an injection of an anti-inflammatory medication to a specific area where there's an area of inflammation or pain. Commonly, we do it in the hand for carpal tunnel syndrome or trigger fingers, and it can last for a variety of times. We don't really know. Everybody is different. Some people it can be curative after one shot, and some people you'll need a series of injections in order to make the symptoms improve. It's sort of like giving an injection of a bottle of Advil into one spot without having the systemic absorption. The nice part about hand surgery is that we don't walk on our hands, and most people have another hand that they can use to do their job. So even if I operate on your dominant arm, I can easily say you can go back to work with no use of your right or left arm, and you still can hunt and peck on the keyboard, and you still can get to and from work without much difficulty. So there doesn't always have to be a lot of time away or down from work with an upper extremity problem. A question I'm asked commonly is, after I get an injection or after I have surgery for a condition, whether it be a ganglion cyst or carpal tunnel syndrome or trigger finger, is it going to come back again? What are the chances that I'm going to have this problem again? And with conditions like trigger finger or carpal tunnel, after surgical intervention, it's unlikely that there's going to be a recurrence. With something like a cyst, there is a chance that it would come back again, maybe upwards of 15% of the time. It can come back in the same spot. It can come back in a different spot. It's just the studies over time have shown that with aspiration of a cyst, it's over a 50% chance of it coming back, so that's sticking a needle in it and sucking it out, as opposed to doing surgery where you actually cut out the cyst and the stalk that feeds it, then it becomes 15%. A trigger finger is when the tendon that flexes the finger gets stuck underneath a ligament that is naturally there, and as the finger flexes and extends, the tendon bounces from one side to the other of this ligament and causes the finger to jump, and that's why it's called a trigger finger. It's most common in patients who are diabetic, suffer from rheumatoid arthritis, or have had a traumatic event occur to their hand. However, it is also possible in any member of the general population for no apparent reason. If you have a trigger finger and you make a fist and your finger gets stuck, then when you try to extend all your fingers, the one finger stays down, and sometimes you're able to pop it open on your own, just with the power of your ipsilateral hand, or sometimes you have to actually take your hand and pop it open itself. Arthritis is when the cartilage wears down between the ends of two bones and the bones begin rubbing on one another directly without cartilage in between. It can cause pain, it can cause deformity, and it can cause limitations in using your joints or hands or wherever it is affecting for normal routines. The second most common area of arthritis in the hand is at the base of the thumb, and it is most commonly affecting women as compared to men because women do more fine motor skills and men do more gross motor skills. And so arthritis in the base of the thumb affects women in a percentage that mimics their age once they get over 65 years old. So 65% of 65-year-old women will have arthritis at the base of their thumb. And it follows as you get older. So 80% of 80-year-old women and so on and so forth. Now, that does say that the X-ray will show that there is arthritis, and if I examine the person's hand they have arthritis, that doesn't mean that it hurts. It just means that arthritis is present. Symptomatic arthritis and X-ray evident arthritis are two very different things. Arthritis doesn't always hurt, and some people have a variety of tolerances for pain, and some people don't do an activity that exacerbates the underlying arthritis, whereas another person may do an activity all day long that causes them pain. Sometimes there are either traumatic injuries or other conditions such as a pigmented lesion underneath the nail that could lead us to have to take the nail off and fix or biopsy the underlying nail bed. And the question I get asked the most is, how long is it going to take for my nail to grow back? So fingernails fortunately grow back 4 times as fast as toenails, and it takes about 6 months for a new nail to grow. However, the first nail that grows back is never a normal nail. It's usually ridged or split or not particularly smooth. So it can take even over 6 months to see a normal, full-grown nail after having an injury to the nail or having had the nail removed. The majority of patients I see are referred either by the emergency department or by their primary care physician. And we're getting much better with our musculoskeletal education in medical school, teaching people, the general population who don't go into orthopedic surgery, what constitutes a problem that would be seen by a hand surgeon. And people are getting much better with their referral patterns. But basically, if you have any question or concern about numbness, tingling, lack of function in your hand, then the hand surgeon is the right person for you to see. The nice part about hand surgery is that the hand and wrist are very well vascularized areas, and they also contain lots of nerves, and they are very easily numbed with the variety of anesthetic medications that we have. So we can give local blocks of numbing anesthesia that can provide pain relief for even up to 24 hours after surgery, where you won't have any pain in the immediate postoperative period. So I see a variety of elbow conditions, anywhere from lateral epicondylitis or tennis elbow to compression of the ulnar nerve at the elbow, which is called cubital tunnel syndrome, to traumatic injuries such as an olecranon fracture, or even possibly tearing of the biceps tendon on the front side of the elbow. Symptoms can be referred to the forearm or wrist, they can be referred up towards the shoulder, or they could just be specifically focused at the elbow. And a lot of times taking care of an elbow condition doesn't only involve taking care of the elbow, but it involves possibly immobilizing the wrist or doing something with the forearm that can also prevent overload of the area in the elbow that is the problem. The elbow has multiple joints associated with it. It has 3 major bones, the humerus, the radius, and the ulna, and it has a variety of nerves and tendons and muscles that travel past it. So there can be a compression of the ulnar nerve at the elbow, which is called cubital tunnel syndrome, which is the second most common nerve compression in the upper extremity after carpal tunnel syndrome. And that can be treated sometimes with something as simple as bracing, or it could be treated with surgical intervention. Symptoms of cubital tunnel syndrome are numbness in the small finger and half of the ring finger. It's basically whatever is left over from carpal tunnel syndrome. You can have tennis elbow, which would be pain on the outside of the elbow, and typically only bad tennis players get tennis elbow, but most people complain about tennis elbow when they're trying to lift heavy bags, such as grocery bags or shopping bags. Surgery for specific conditions in the elbow can be very effective, such as cubital tunnel release, where we take the ulnar nerve out of the area where it is being compressed and allow it to have an improved blood supply and flow of information. Whereas other conditions that can be more degenerative, such as tennis elbow, don't always have the best outcomes after surgery. Elbow surgery can require either physical or occupational therapy. It again is a time-consuming therapy, but with time comes great gains in range of motion and flexibility. The elbow is not a joint where you can gain all your motion back in a short period of time. It can get stiff very quickly, and then it takes a long time to become more flexible. So immobilizing the elbow for long periods of time is not ideal. Long arm casts or other ways of immobilizing the elbow are okay for kids because kids are resilient and flexible. For older folks that can get stiff easily, the goal is to keep them immobilized for less than a week if possible. Elbow arthritis is common, but end-stage degenerative arthritis of the elbow is less common, mostly because we don't walk on our arms, so the elbow and the wrists don't see the amount of force that our knees and our hips see. But at times, people can have degenerative changes in their elbow that become so bad that they're unable to bend their elbow even 10 degrees without excruciating pain. At that time, we would consider an elbow replacement. An elbow replacement surgery is much like a knee replacement surgery, where we recreate the hinge with metal and plastic to allow the elbow to move more freely. Now, the only caveat to doing an elbow replacement is that it comes with a lifetime limitation of no weightlifting or weight bearing over 5 pounds. So the person who's suffering from the arthritis in their elbow has to have a real compelling reason to need the surgery, and that they will adhere to the regimen of no lifting over 5 pounds. That's a half a gallon of milk for the rest of their life. Because if they overdo it with their elbow, the prosthesis can get loose either in the humerus or the ulna. It has a chance to get infected and then would need to get revised and redone. Similar to the wrist and the hand, we don't walk on our arms, so having an elbow injury or elbow surgery would not preclude you from going to work. There needs to be time dedicated to going to therapy, so you may have to have a shortened time at work, but isolating and not using the affected arm shouldn't prevent someone from being able to actually be present at work.